Welcome to the module on adult acute leukemias and myelodysplastic syndromes. I'm Anthony Personati. I'm a clinical pharmacist specialist at the University of Michigan. I practice in hematology. My day-to-day is to take care of patients with acute leukemias and MDS. This presentation is part of the ASHP ACCP Oncology Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. This activity is designed to be interactive with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in the handout. The disclosures are displayed on this slide. Today, I'm going to take you through the entire patient experience from A to Z. Now, when a patient walks into your clinic or emergency room with a suspected new diagnosis of MDS or acute leukemia, we as pharmacists, we are part of a team that helps manage life-threatening complications. We help our team identify and obtain the right diagnostic tests because these tests help us with the prognosis and they help us with identifying the proper treatment selection. We then help our teams with explaining the literature to guide their treatment selection. And lastly, we help our patients get through their treatment course. We do this by monitoring, preventing, and treating adverse events related to their treatment. And those, ladies and gentlemen, are the objectives for today. We will start off with myelodysplastic syndromes. To help me articulate what MDS is, I want to illustrate it first in the case. So here we have a 69-year-old female, no past medical history. She presents to her PCP with significant fatigue. Her PCP does some blood work and notices that she has several cytopenias. Her neutrophil count is low, her hemoglobin is low, her platelets are relatively low. And so her PCP then sends her to a hematologist where a bone marrow biopsy is performed. And the bone marrow biopsy reveals a few things. First, dysplastic changes. Second, 4% blasts. Third, ring sideroblasts. And so the diagnosis here is consistent with de novo myelodysplastic syndrome. We obtain cytogenetics, they are normal. We obtain some molecular tests as well. One of them comes back as positive, and that is an SF3B1 mutation. In clinic, we calculate the patient's IPSS-R score, and we demonstrate that she is a low risk MDS. Her EPO-Eaton level is 640 units per liter. What is the most appropriate treatment for CJ at this time? Is it A, decitabine, B, lenalidomide, C, EPO-Eaton with or without filgrastim, or D, Luspatercept? The correct answer here is a newly FDA-approved agent called Luspatercept. It was FDA-approved in the last year or so for patients with lower risk MDS with ring sideroblasts. So the ring sideroblasts are a key finding here. A patient with an SF3B1 mutation, although not required, it will also help predict response. So a couple of reasons why decitabine is not correct. Well, typically we reserve decitabine and chemotherapy for patients that really need reversal of their disease. So typically we'll reserve this for patients that have failed multiple therapies for lower risk MDS or a patient with higher risk MDS. Now, B is incorrect, lenalidomide. We typically will reserve lenalidomide for a patient with deletion 5q, or additionally, I like to use it in patients with lower EPO levels after they failed EPO-Eaton. Now, C is incorrect, EPO-Eaton, mainly because this patient's EPO level is already high. So a patient with an EPO level greater than 500 is considered high. Giving more EPO is not going to help this patient. Now, if anyone listening is like me and they see this word myelodysplastic syndromes, the first question that I ask myself is, what does this even mean, right? Let's break this down a little bit. So myelo means bone marrow, and so we have myeloid progenitor cells in the bone marrow. Dys means abnormal, plastic means growth. Thus, we have a syndrome characterized by abnormal growth in the patient's bone marrow. Okay, so we're halfway there. I kind of get it, but I think relating it to a patient is incredibly helpful. And the classic example is an older patient that we just went through in that patient case, a typically 70-year-old, presents to their PCP, fatigue. 90% of patients with MDS will have anemia. And these cytopenias can get progressively worse, where their white blood cell counts drop, their platelets drop. And ultimately, you have a diagnosis of MDS when they have stable cytopenias for 6 months, and you've ruled out all of their causes. Now, we draw a line in the sand, though. We do not allow 20% blast, because once you hit the 20% blast threshold, you are now acute myeloid leukemia. And so the reason why these patients have low blood counts is this abnormal growth in their bone marrow. So when you do a bone marrow biopsy, what you'll see is a tremendous amount of immature cells, a hypercellular marrow. And all these immature cells, they're not functioning properly. They're dysmorphic. Their nucleus looks like blebs or lava lamps. And they crowd out the entire marrow and do not allow normal hematopoiesis. So ultimately, you have a syndrome with ineffective hematopoiesis and low counts. Age is the strongest risk factor for MDS. It's actually quite rare in young patients to have de novo MDS. Most of the time, they'll have secondary MDS that was caused by previous chemotherapy that they received for another malignancy. Typically, our alkylating agents or our topoisomerase 2 inhibitors are the two notorious classes that can cause a secondary MDS. And the prognosis for secondary MDS is much worse. The way that we can determine a prognosis for our de novo MDS patients is by using some prognostic scoring tools. And there are several tools that can be used. I typically will use the IPSS-R. Now, in your handout, you'll find several tables for your reference and also for your additional understanding. I left them off the PowerPoint because I do not want you to spend your time memorizing them. Just understand them, understand what goes into them. And the nice thing about it is it's common sense. The higher your blast percentage you have, the more points you get and the worse your prognosis is. The more cytogenetic abnormalities you have, or if you have high risk cytogenetic abnormalities, you will get more points and therefore your prognosis will be worse. If you have multiple cytopenias, your white count's down, your hemoglobin's down, your platelets are down, you will do worse. And what I mean by doing worse is you're more likely to progress to AML and your life expectancy is going to be much shorter. Now, in reality, and hopefully, with test questions, they will give you the diagnosis, the patient has MDS, and they should hopefully give you the patient's score, whether they are a high-risk MDS or a lower-risk MDS. In the clinic, we use these prognostic scoring tools to help us categorize if our patient is in lower risk or higher risk MDS. And you'll see that depending on which scoring tool you are using, you'll have different points. And then once you get your points, you will then assign a specific risk. And then within that risk, you finally decide whether you are lower risk or higher risk. What I want you to take home as the take-home message is that we have lower risk MDS and we have higher risk MDS. Don't think too much about the very low or intermediate one. For treatment purposes, we really just break things up into lower risk and higher risk. So let's try to keep things simple. And again, hopefully, tests do not require you to do all these calculations because there's really no way. And I do this on a daily basis and I don't memorize all these scoring tools. The goals of therapy for MDS are threefold. Number one, we need to prevent our patient from transforming to AML. Number two, we cannot have our patients come into our infusion centers getting blood transfusions multiple times per week. Red blood cell transfusions lead to iron overload, and long term, this can lead to cardiac dysfunction, liver dysfunction, endocrine dysfunction, and ultimately can increase their mortality. So we really want to try to decrease their needs for blood transfusions. And then 3, we need to improve their quality of life. And some of that quality of life is preventing blood transfusion. It's preventing infections. It's preventing them from having life-threatening bleeds. So in a patient that is asymptomatic with their MTS, there's no need to start them on treatment. Some therapies can actually worsen their quality of life. However, some patients have significant disease-related symptoms that the toxicities of these therapies will be worth the improvement of their disease-related symptoms. And unfortunately, we cannot cure MDS. We can try to cure it with an allo transplant, but for the most part, most patients are not cured. Here are some categories of specific classes of agents that we have for lower risk MDS. We have our growth factors like EPO and filgrastim, immune suppressive therapy, which I'll show you a specific population that may benefit. We have lenalidomide, luspatercept, and our hypomethylating agents. And I'll go through exactly where these should be used versus not used in a nice algorithm shortly. As I mentioned earlier, about 90% of patients with MDS will present with anemia. And so, trying to combat the anemia is one of the first things that we'll do. And we can use erythropoietin stimulating agents. However, there is a population that will benefit versus a patient population that won't benefit. And so what I want you to take home from this slide is that patients with an EPO level less than 500 are appropriate candidates for an ESA if they have anemia. If their EPO level is greater than 500, the likelihood of response is quite low, and therefore we just skip to the next line of therapy. I mentioned that immune suppressive agents are a potential modality, and there's a very specific patient population that we would consider this in. Typically, these are younger patients that have a hypocellular marrow. There are other characteristics here, but I think, if you can remember that young patients, because young patients really shouldn't get MDS, especially if they've not been exposed to, previous chemotherapy. Young patients with a hypocellular marrow, those are patients that we would consider using immune suppressive therapy. But for the rest of all of our patients, immune suppressive therapy typically does not work well. We have a second patient case to learn from here. You have a patient here that is awaiting their bone marrow results. And in here, we're particularly interested in the cytogenetic analysis because your physician is wondering, is there an oral medication option to treat MDS? And you do know that lenalidomide is oral. You also know that there is now an oral decitabine formulation approved for MDS. So in this case, your physician is wondering, is there a specific cytogenetic feature that would sway you to use lenalidomide? Is it a patient with A, deletion 12p, B, deletion 5q, C, a FLT3 internal tandem duplication, or D, a patient with normal cytogenetics? And the correct answer here is B. Deletion 5q equals lenalidomide. And it's as simple as that. There's really no need to explain anything else. Just know that patients with deletion 5q are exquisitively sensitive to lenalidomide. For those of you listening at home right now, this could get a little weird, but hopefully you're listening by yourself. And so what I want you to do right now is repeat after me. Deletion 5q equals lenalidomide. Deletion 5q equals lenalidomide. It's as simple as that. That's something that, test questions love a specific target or a specific cytogenetic marker to tell you what drug to use. So I just saved you potentially a test question, despite making you potentially look weird by repeating deletion 5q and lenalidomide. So this subtype actually confers a very favorable prognosis. And typically these patients will only have anemia, which makes lenalidomide a little bit easier to use. When patients have thrombocytopenia or neutropenia on top of the anemia, lenalidomide can be tough to use. So fortunately, deletion 5q, they're anemia only as a presentation in general. Now we can use lenalidomide outside of deletion 5q. It gets tricky of when to use it in these patients, especially with the advent of Luspatercept. But typically what I would say is if a patient has a low EPO level, I would use EPO first. If their EPO level is high, I would probably avoid lenalidomide because the efficacy is actually quite poor in patients with high EPO levels. And so I think a patient without a deletion 5q, it would be reasonable to consider in a patient that had a low EPO level, failed EPO, and then now you're moving on to another therapy. And in this case, you can choose between typically lenalidomide, or I'll show you in our algorithm some other agents. So lenalidomide's nice because it's oral. There are some adverse effects. As I mentioned, the myelosuppression can be pretty challenging in MDS. VTE is not so much of a concern in MDS. It's more of a concern in multiple myeloma. Certainly can cause diarrhea and some skin reactions. And as you know, it is teratogenic. Fortunately, these are 70-year-old patients. Although we still have to counsel them, you have to counsel them on not getting pregnant. Luspatercept is a new agent that we can use in MDS, and it was FDA approved based off of the Myelodysplastic trial. Now you'll see some important inclusion criteria. Luspatercept is used after patients have failed EPO-Eton or in patients that are unlikely to respond to EPO. Now these patients do not have deletion 5q because deletion 5q, we would use lenalidomide. And these are patients with lower risk MDS based off the IPSS-R score. You'll also notice that I bolded in red is like our patient case, patients have to have ring sideroblasts or also an SF3B1 mutation. So the Myelodysplastic trial randomized patients to Luspatercept. This is a subcutaneous injection every 3 weeks, or placebo. This was a multi-center phase 3 double-blind randomized controlled trial. The primary outcome is red blood cell transfusion independence at 8 weeks. So this is an agent that hopefully can boost the patient's red blood cells. When I think about hematopoiesis, I think of a car factory and an assembly line. There are different stages of putting together a car, just like there are different stages of red blood cell maturation. The early stages of red blood cell maturation depend on EPO-Eton, to mature. In the later stages are inhibited by two things. One is called GDF11, and the second thing is called SMAD23. Again, imagine that a car is going down the line, or red blood cells are going through maturation, and you put a halt on the line. It stops moving. Nothing can be built. It's stuck. The red blood cell is stuck. It will no longer differentiate, and it will no longer mature. Well, it's GDF11 and SMAD23 that are causing this halt in maturation. Luspatercept is a recombinant fusion protein that will bind GDF11. Now, GDF11 binds to the ACT-R2B receptor, which that receptor then signals SMAD23, and SMAD23 tells the cell to stop transcribing, stop becoming more mature. So we can actually shut down the cell from telling us to stop mature by getting rid of GDF11, and that's exactly what Luspatercept does, is it will grab GDF11, which is halting this line, it's halting the maturation of a red blood cell, and then the signal to tell the cell to stop maturing is now gone. And this cell, this red blood cell, can now progress on, and the line is now back up and running, and the red blood cell, the car, is now going to become a full functioning car or a full functioning red blood cell. Another point to be made about this mechanism of action is it is completely independent of EPO. It does not matter if your EPO level is high or your EPO level is low, Luspatercept will work regardless. Whereas remember, if you have a high EPO level, giving more EPO will not work. You can only use EPO if your EPO levels are low. With Luspatercept, does not matter what your EPO level is. Going back to the Medalist trial, the results here, you'll see that patients were more likely to be transfusion independent if they received Luspatercept than if they received placebo. So these are patients that are no longer having to get red blood cell transfusions very frequently. Some of these patients are going 8 weeks without a transfusion, some patients 12 weeks. And this was more likely to occur with Luspatercept compared to placebo. For the most part, Luspatercept is well tolerated. Grade 3 or 4 or these high grade adverse effects are really no different between Luspatercept and placebo. However, there are differences in grade 1 or 2 adverse events. Luspatercept is a little bit more challenging to tolerate with lower grade reactions. There is more fatigue, more diarrhea, more nausea, dizziness, headache, and everything else that's listed on this slide. So something to keep in mind. Luspatercept requires a few things before it is indicated in your patient. First, this is a patient that has to have failed an erythropoietin-stimulating agent, or it could be a patient that you would anticipate just not going to benefit from an ESIA, like a patient that has an EPO level greater than 500. Your patient also has to have required 2 or more red blood cell units over the last 8 weeks. And it also needs to be a lower risk MDS patient. So remember, I categorize MDS as lower risk or higher risk. And patients that are very low up to intermediate risk, I simplify this by just saying this is lower risk MDS. So it's a lower risk MDS patient based off of the IPSS-R score. And it also has to be a patient that has ring sideroblasts. The dosing is something that you should keep in mind. So a lot of times we are using Luspatercept sort of in our either our leukemia clinics or our anemia clinics, and they can be managed by pharmacists because there's specific dosing recommendations, and the dosing recommendations are listed here. And it's very similar to how we use ESAs, where if their hemoglobin is not increased by a certain amount or the patient is still requiring transfusions, we'll increase the dose. And if their hemoglobin goes too high too fast, we'll decrease the dose. Let's do a quick recap here. We've talked about erythropoietin stimulating agents for patients with low risk MDS with primarily anemia only. And we talked about how patients that have an EPO level less than 500 are most likely to respond to an ESA. However, patients with an EPO level greater than 500 are unlikely to benefit. And so we move on to our next therapies. A patient with deletion 5q is going to benefit from lenalidomide. And a patient who has failed an ESA or is not going to respond to an ESA with ring sideroblasts is a patient that we would consider Luspatercept. Now, when all of these therapies fail, we will then move on to our chemotherapy, our hypomethylating agents. And we have 2.5 agents FDA approved and available to us. We have azacitidine and we have decitabine, both an oral formulation and an intravenous formulation. Now, these drugs will help reverse the disease complications. They may make the disease a little bit worse before they get better, but ultimately have some control over the disease, whereas the other agents that we talked about, for the most part, will only help with the cytopenias, but not actually reverse the disease course, with the exception of lenalidomide for deletion 5q. Now, azacitidine is the only hypomethylating agent that has been shown in a phase 3 randomized controlled trial that it can improve overall survival. However, right now we do have an international shortage of azacitidine. I am comfortable substituting azacitidine for decitabine for MDS. And I did a lot of talking where I tried to describe to you how we treat MDS. However, sometimes a picture is worth 1,000 words. And so here's a nice figure here that I put together for y'all to kind of visualize how we're actually treating lower risk MDS. So a patient with symptomatic anemia, the first question you're going to ask yourself is, does my patient have a deletion 5q? And if your patient does, bam, lenalidomide. If your patient does not have a deletion 5q, the first question you're going to ask yourself is, what is my patient's EPO level? Remember, high EPO levels, EPO eaten is not going to work. Low EPO levels, less than 500, great candidate for an ESA. So that's what we'll start with. Well, when the patients then fail our ESA, we then will move on and ask a question, does my patient have a certain percentage of ring sideroblasts or also an SF3B1 mutation? And the answer to that is no. Lenalidomide is reasonable. It's an option. Many of us may just choose to move on and go to our other chemotherapies because the patient doesn't have a deletion 5q. Now, if a patient does have a certain amount of ring sideroblasts or an SF3B1 mutation, we will consider Luspatercept in that patient. Now, if the patient then fails all these therapies and we really need to get some control over their disease biology, we'll then move on to our hypomethylating agents like azacitidine, decitabine. You'll notice that for lower risk MDS, we typically will not offer a transplant, an allo transplant to these patients, because these patients can live several years, if not decades, with their MDS, and the risks of transplant in an older population is not warranted in this case. For patients with higher risk MDS, however, allogeneic stem cell transplant, if the patient is fit and young enough for one, would be your first line therapy. Okay. You'll also notice for higher risk MDS here, there's no ESAs, there's no Luspatercept, there's no lenalidomide. We really need to get a fast control on these patients' disease biology, and we do that by either offering them an allo transplant or trying to reverse things with our hypomethylating agents, and rarely will we do intensive chemotherapy. Hypomethylating agents are a standard of care for higher risk MDS. They have shown an overall survival benefit, primarily azacitidine has. When we would use them? Well, in a patient that is not a candidate for stem cell transplant, or if we know that it's going to take several months to find our patient a donor for their transplant, we might actually use our hypomethylating agents as a bridge. The other place we might use them is after they've failed an allo transplant. Typically, I do not offer patients the option of intensive chemotherapy just because, one, we don't really know which intensive chemotherapy actually works or which one is the best. We do know that 3+7 does not work well for patients with secondary leukemias, and therefore, these patients have pretty limited options, and intensive chemotherapy in 70-year-olds have a high mortality rate. So typically we'll not offer patients intensive chemotherapy as frontline, but I feel compelled to put this in here as an option because it is an option in the NCCN guidelines. But again, typically we're offering them an allo transplant or giving them a hypomethylating agent only until both of those options are no longer options for patients, whether they failed them or just were not options for the patients, would I then consider intensive chemotherapy. And there isn't really a standard of care of which intensive regimen to use. Summarizing how we treat higher risk MDS. Again, a nice picture for you all to kind of visualize this. And this is a little bit more simple than lower risk MDS. First thing you ask yourself, is my patient a transplant candidate? If they are, get them to transplant. The transplant is the only potential curative option for these patients. If you have your donor available, get them there right immediately. You don't have to give them chemotherapy. If they have a high disease burden, you can consider giving them a hypomethylating agent to reduce their blast percentages, but ultimately try to get them to transplant as soon as possible. If their transplant donor is not ready, we would bridge them with a hypomethylating agent. Again, intensive chemotherapy is in the NCCN guidelines. It's an option, but typically not used by many of us. Now, if your patient is not a transplant candidate, that's when we would typically use just a hypomethylating agent. Again, I don't really have a preference. NCCN prefers azacitidine mainly because it has overall survival advantage in a phase 3. With the shortage, I do not mind whether it's azacitidine or decitabine, whether it's IV or oral. Ultimately, the best therapy always is a clinical trial. We will move on now to acute myeloid leukemia. We have a 64-year-old female that is presented to your acute leukemia service who has a past medical history of diffuse large B-cell lymphoma that was previously treated with R-CHOP. She's admitted for new symptoms of newly diagnosed AML. She is negative for NPM1 FLT3-ITD and FLT3-TKD. However, she is CD33 positive. Her cytogenetics reveal a deletion 7. Prior to her admission, she was running 5 kilometers per day. I'm Canadian, that's why I put kilometers instead of miles. Which of the following is the most appropriate at this time? Is it A, 7 plus 3 using daunorubicin 45 milligrams per meter squared? Is it B, 7 and 3 daunorubicin 90 milligrams per meter squared? Is it C, liposomal cytarabine and daunorubicin, aka Vyxeos, aka CPX351, plus gemtuzumab, or is it D, liposomal cytarabine and daunorubicin? Okay, so the right answer here is liposomal cytarabine and daunorubicin, formerly known as CPX351. And the reason for this is this patient has secondary AML. It's secondary because the patient previously received either a topoisomerase 2 inhibitor or an alkylating agent, both of which are inside of R-CHOP. So she has secondary AML, and we know that patients that are receiving 3+7, whether it's A or B, these patients have a lower complete response rate and a worse overall survival. Now C is incorrect because I would not add gemtuzumab to liposomal cytarabine and daunorubicin. 1, it's never been studied, and 2, it would be incredibly toxic. Let's go over the classic presentation of acute myeloid leukemia. Well, first, they always come in the middle of the night or at 5 p.m. on a Friday, right when you're ready to go home, right? First things we need to do is ensure patient safety. Make sure that they do not have any hematological emergencies. Number 1, hyperleukocytosis. If they have a very high white count, start hydroxyurea. The dosing is somewhat arbitrary. Usually I'll just start with 2 grams every 8 hours. We get a pathology involved to perform leukapheresis. We give them fluids, and we try to hold off on red blood cell transfusions to prevent worsening leukostasis in a patient with super hyperleukocytosis. Second thing, infections. Infections can also kill our patient. So if a patient's coming in with febrile neutropenia, start an anti-pseudomonal beta-lactam. Third thing that can commonly present is DIC. So we're going to check our patient's fibrinogen, their PTT, their INR. We're going to replace with cryoprecipitate and FFP as appropriate. Number 4, tumor lysis syndrome. Start normal saline. Monitor their potassium, phosphorus, uric acid, serum creatinine. I start them on allopurinol. And if above your institutional threshold, some say 8, mine's much higher, you can consider rasburicase. I usually try to give fluids for at least 24 hours and try to give a good college try before I'm pulling out resburicase. And like I said, my thresholds are a little bit higher, but do what you think is safe at your institution, and obviously think about cost too. So after you prevented imminent death, you're going to finish the workup. You're going to do a peripheral smear to look for blasts. You're going to do flow cytometry. Flow is going to look on the outside of the cells to see if there are cell surface antigens. That's going to help us determine, is this a myeloid progenitor cell or is this a lymphoid progenitor cell? If these acute blasts are lymphoid, well, that's acute lymphoblastic leukemia, which we're going to talk about in the next section. If they're myeloid blasts, obviously this is now AML. We also do things like cytogenetics, whether they're karyotyping or FISH, where this is just fancy terminology to say we're looking for broken, missing, or added chromosomes. We'll then do some molecular or next generation sequencing, because you're going to notice in this chapter, molecular diagnostics are very, very important, not just for prognosis, but now for selecting therapies as well. And we're going to wait for some of these tests to come back to help us identify what treatment we're going to use. And finally, to make the final diagnosis, we need, remember, drawing that line in the sand, 20% blasts. If they're less than 20%, your MDS, 20% or higher, your AML. With a couple of caveats. There's always caveats, I'm sorry. One of the caveats is it does not matter what your blast percentage is if you have specific cytogenetic abnormalities like translocation 821 or inversion 16 or translocation 1616, which together those three we call our core binding factor leukemias. Or if you have APL, which APL is characterized by translocation 1517. Before we start thinking about selecting therapies, the first thing that I do is go look at my patient, right? So it's very hard to determine your patient's biological age from a computer. Sure, you can know accurately their chronological age. And what I mean by biological age is when you look at your patient, you can tell, are they really a 70-year-old or are they a 70-year-old who is, running through the halls with their infusion pump? They've just went outside shoveling snow, running marathons, chopping down trees, right? That's not a true 70-year-old. So you can see this when you walk in your patient's room. So knowing your patient's age and their performance status is important. Knowing their comorbidities is going to help you identify what therapy might be best for them. Knowing whether they have secondary AML is going to change how you treat, right? You're going to use liposomal daunorubicin cytarabine. We'll look at other comorbidities like, do they have heart failure? Well, can't really use an anthracycline there. Do they have renal failure? Do they have liver failure? Do I think they have comorbidities that might preclude them from tolerating intensive therapy? So we're, really giving our patient the up-down before we're really embarking on intensive chemotherapy. Going back to some of the cytogenetic molecular tests, NCCN now recommends that you expedite the molecular and cytogenetic tests, mainly because they could, in some instances, change your backbone of chemotherapy, or they could change what you add on to your backbone of chemotherapy. So listed here, I have the ELN and now the NCCN cytogenetic and molecular risk stratification for AML. And I'm sorry, this is a really complicated table, but it's like our holy Bible. This is very important, risk stratification. But so let me try to simplify this for you. First, let's look at the bottom, okay, the adverse. Number one, if you see a negative sign, that means it's a deletion or a loss in a chromosome. That is bad. Anytime you lose genetic material, that's bad. So deletion 5, bad. Deletion 7, bad. Deletion 17, bad. Deletion anything, bad. Number two, if you have several lines worth of mutations, that's bad. We call that a complex karyotype if you have 3 or more mutations. Number three, P53 is bad. And this is not unique to AML. Losing or mutating P53 is bad everywhere. FLT3 mutations, they're bad. We certainly will look at the allelic ratio, but for the purposes of what we need to do and what we need to use this table for, and that's to recommend an allo transplant, you just need to know that FLT3 is bad and that FLT3 is targetable. It's very controversial. This allelic ratio business is still very controversial. So I don't want to talk about it because it's going to get confusing. And I don't think it's testable because of how controversial it is. I would skip intermediate and let's just go right to favorable. What you need to know in the favorable is that core binding factor leukemias, remember 821 translocation, inversion 16, translocation 1616. These are our core binding factor leukemias. These patients are good risk, okay? From a molecular perspective, NPM1 is good, CEBP alpha are also good. Just to drive some of the molecular mutations home again, FLT3, like I said, is bad. And it really doesn't matter whether you're an ITD or a TKD for the purposes of testing. Again, it is something that you're going to target with a FLT3 inhibitor. NPM1 is a good prognostic factor, and CEBP alpha is a good prognostic factor. In AML, we have two phases of treatment. One we call induction. In induction, the goal is get the patient into a complete remission. And consolidation or post-remission therapy, that is where we want to keep them in remission. They're already in remission, but we need to consolidate it and keep them in remission. Certain patients do better than other patients, like patients who are younger, have a good performance status, more favorable cytogenetics and molecular profiles, and those that are able to stay in remission longer and have a more durable remission, they also do better. For the purposes of this presentation, I'm going to categorize how we treat AML into three broad buckets. First is going to be patients that are less than 60 years of age. Second is going to be greater than 60 years of age, but are fit for intensive chemotherapy. These two buckets, our goal is get them in a complete remission and, get them cured. The third bucket that I want you to remember is those that are not fit for intensive chemotherapy. In this case, although our goal is still get them in remission, most of these patients, unfortunately, we cannot cure. Most of these patients are older patients. Now, when it is available, we will use some predictive biomarkers to help us select our therapies. These predictive markers are FLT3, IDH1, IDH2, and CD33. And as pharmacists, these are important because we have drugs that can target these biomarkers. I have NCCN algorithms inside of this presentation that you can review, but to give you a little sneak peek, for FLT3, midostaurin is used in the front line in combination with 3+7. Gilteritinib is used in the relapse refractory setting. IDH1 and 2 inhibitors are used for patients that are too frail for intensive chemotherapy. And gemtuzumab is used in combination with 3+7 for patients with favorable and intermediate risk cytogenetics. A question one of our leukemia attendings likes to trick our fellows with is, you gave your patient 3+7, and on day 28, you performed a bone marrow biopsy where you found no blasts. Is your patient in remission? And, everyone always thinks, oh, they don't have a blast. Yeah, sure, they must be in remission, right? And literally every time he comes on rounds and asks this, I chuckle because he tricks everyone every single time. And the answer to that is, well, you can't answer that question because you don't know. They didn't give you all the criteria that you need. You need to see whether or not your patient has count recovered. You need to see not only no blasts, but you also need to see that your bone marrow has woken up and producing normal cells. And therefore, you need no blasts or less than 5% blasts. And you need a normal hematopoiesis. So your ANC needs to be above 1, your platelets have to be 100, and you have to be independent of blood transfusions. When I was in residency, treating AML was actually really easy. It was, if you were fit for intensive chemotherapy, you got 3+7. Unfortunately for you all taking the test or trying to learn AML now, it has got incredibly more complex. There are many other subtypes of AML that you have to be thinking about. But historically, standard of care was 3+7, has been the standard since 1973. And the regimen also got solidified when Bob Lowenberg and Fernandez published some publication showing that if we intensify our anthracycline in 3+7, we get even better outcomes. So the standard of care for the dosing of daunorubicin, to me, is 90 milligrams per meter squared. There are some, and even NCCN, that say that 60 is okay. For the purposes of this test, I want you to know that anywhere from 60 to 90 per meter squared is the standard of care for AML when you're using 3+7. The equivalent to this would be idarubicin, 10 to 12 milligrams per meter squared. This is what I'm talking about. We had literally nothing for 50 years. And all of a sudden, we just had an explosion of new drugs. We had 10 new FDA approvals of drugs that we could potentially use in AML. So how do we sort through all this? Let's sort through them together here. Let's start off with an easy one here. Here is a population of patients with FLT3 AML, both ITD and TKD, and patients were randomized to receive 3+7 with placebo or 3+7 with midostaurin. And midostaurin improved overall survival, and thus it became the standard of care for patients with FLT3, ITD, and TKD mutations. As pharmacists, there's a few adverse effects that you should be aware of. One, it can cause some myelosuppression, it can cause some rash, nausea. I don't know how in this clinical trial the nausea was actually higher with placebo. Anyone that uses this drug in practice knows this is incredibly tough for our patients to tolerate. So typically we will give Zofran before every single dose of midostaurin because it is that hard for our patients to tolerate. You should also know that there are significant drug interactions with our azole antifungals in early trials cause some pulmonary fatal events. And so there are a variety of different ways that we go around this, whether it's using moderate inhibitors or using echinocandins. Moving on to secondary AML, similar to the patient case that I brought up earlier. So this is a patient population 60 years to 75 years of age. So they're older but fit for intensive chemotherapy. Patients were randomized to liposomal daunorubicin cytarabine or CPX351 versus 3+7. The consolidation is listed there. And this study led to an overall survival benefit with CPX351. Although the efficacy was improved with liposomal daunorubicin cytarabine over 3+7, there are some notable toxicities, and I think the most notable should be the myelosuppression that can be caused by this agent. Patients can take a considerable amount of time to recover their counts. Some patients can take a couple of months to recover their counts. And remember, these are older patients that have secondary leukemia that may have came in with already lower counts. So the length at which they have neutropenia, thrombocytopenia can cause complications. And okay, the gemtuzumab saga. This was very perplexing to me, and honestly, I was taken aback when the FDA reapproved gemtuzumab. It was initially approved based off an accelerated approval, but then was pulled from the market because it did not meet a primary endpoint. It didn't improve overall survival in a confirmatory study. However, all of a sudden in 2017, the FDA reapproved the drug. So let's try to figure out what happened here. The Alpha 0701 trial really helped gemtuzumab get back on the map and get re-FDA approved. This is a population of untreated AML. These patients were randomized to receive 3+7 with gemtuzumab or 3+7. The primary endpoint here was event-free survival. Although the event-free survival was dramatically improved with the addition of gemtuzumab to 3+7, there was no benefit to overall survival. There is considerable toxicity also with gemtuzumab, similar to CPX-351. The myelosuppression can be quite significant, the thrombocytopenia, persistent thrombocytopenia that can cause hemorrhage. But one of the things that you should really remember is the VOD or SOS, sinusoidal obstructive syndrome. This is a life-threatening disorder that can cause liver failure. All of the cases that occurred in this trial occurred because of gemtuzumab, whether it was in the gemtuzumab arm or it was the control arm that crossed over to gemtuzumab eventually. Those patients also got VOD or SOS. So this is something that we worry about, especially in patients that need to go to transplant. A major limitation to the gemtuzumab data is there's conflicting reports as to whether or not gemtuzumab improves overall survival. And so Hills and colleagues decided to perform a meta-analysis thinking that perhaps the studies were just underpowered or not designed to show an overall survival benefit, or perhaps they could find a subgroup that may derive benefit from the addition of gemtuzumab to chemotherapy. Hills found that overall gemtuzumab does not improve overall survival in AML. However, they found two subgroups that may derive benefit. The first is favorable risk cytogenetics. These patients had an overall survival benefit. Remember, favorable risk cytogenetics. These are our core binding factor leukemias, patients with translocation 821, inversion 16, translocation 1616. These are arguably the one place that many centers are using gemtuzumab, if they are using gemtuzumab. The second is sort of a soft call, but they did find an overall survival benefit, and that is our intermediate risk category. So that's the in between, the middle group inside of the table that I showed you. Patients with adverse cytogenetics do not benefit from the addition of gemtuzumab. Here's a summary of how the NCCN recommends the treatment of AML. I split them up into cytogenetic classifications because this really does change potentially how you would treat AML, and then some molecular characteristics. You'll notice that across the board for young patients less than 60 years of age that can tolerate intensive chemotherapy, 3+7 is still the standard of care. If you have a FLT3 mutation, you will add midostaurin to 3+7. If you have favorable or intermediate risk, you can consider adding gemtuzumab. However, the standard of care still is 3+7. If you have secondary AML, and this I want you to remember because this is a little bit different in older patients. Here for secondary AML, 3+7 is still a category 1 recommendation, but you can consider using liposomal daunorubicin. In older patients greater than 60, which were included in the trial, 3+7 would not be appropriate in a patient with secondary AML. Liposomal daunorubicin cytarabine would be the standard of care. Okay, so we got our patient into remission. What do we do next? What do we do for consolidation? The patient has good renal and hepatic function. Would we do A, cytarabine 3,000 milligrams per meter squared, Q12 hours on days 1, 3, and 5? B, cytarabine 1,000 milligrams per meter squared IV, Q12 hours on days 1, 3, 5, plus gemtuzumab? C, liposomal daunorubicin? Or D, 5+2? And remember, this is a patient, RO, that we had previously who has secondary AML. C is the correct answer, liposomal daunorubicin cytarabine. For an older patient greater than the age of 60, the standard of care for secondary AML is liposomal daunorubicin cytarabine induction, and then once they get in remission, to also consolidate them with the same drugs. Different dosing, but still liposomal formulation. A would be correct for virtually all of our other patients that have received intensive chemotherapy with 3+7. D, I would not consider for almost any patient for the most part, mainly because I think that high dose Ara-C is very important for patients. High-dose Ara-C is the standard of care based off of a study published in 1994 by Mayer and colleagues that showed that it improves patient survival if you consolidate with high-dose Ara-C. There are some toxicities that we should know as pharmacists, and that is our cerebellar toxicity. So these, before each dose, we're doing the finger-to-nose test. We're having patients sign their name to make sure that they still have proper cerebellar function. The other toxicity you should know about is the ocular toxicity that we can prevent with using corticosteroid eye drops. And certainly there are other consolidative regimens, and that's based off of what regimen you gave. So if you gave liposomal daunorubicin, you're going to consolidate with that. If you gave a gemtuzumab containing regimen, you can consider consolidating with a gemtuzumab-based regimen as well. Here we have a 62-year-old female presenting to your ED with a low white blood cell count, low platelets, doesn't have a past medical history, and she was training for the Boston Marathon next month. Unfortunately, she's diagnosed with AML and is found to have a complex karyotype, also has an IDH1 mutation, and is CD33 positive. Which of the following treatments is most appropriate? Is it A, gemtuzumab, B, ivosidenib, C, azacitidine, venetoclax, or D, decitabine, enasidenib? The answer here would be C, azacitidine, venetoclax, and the reason for this is this patient has a complex karyotype. Gemtuzumab does not work well in patients that have unfavorable cytogenetics. Ivosidenib, I would generally reserve in the frontline setting for a very elderly patient, not this patient. Decitabine and enasidenib is not a standard of care combination at this time. And here's the treatment algorithm for greater than 60-year-olds, but fit for intensive chemotherapy. You'll notice that 3+7 is not necessarily a category 1 recommendation anymore, but it's still an option. Favorable risk, intermediate risk cytogenetics, you can consider adding gemtuzumab. You'll notice again, secondary AML, 3+7 completely gone. Liposomal daunorubicin cytarabine is the standard of care for patients greater than 60 with secondary AML. And in this case that we just went through, patients with unfavorable risk cytogenetics, like our case who had a complex karyotype, venetoclax with a hypomethylating agent is an appropriate option. Indeed, a patient with a FLT3 mutation, we typically will induce with 3+7 in a fit patient, despite being over the age of 60, and we would add midostaurin. We talked about patients who are fit for intensive chemotherapy. What about patients who are frail or older patients that won't tolerate intensive chemotherapy, patients who would have a high induction mortality rate with intensive chemotherapy? Historically, we have used single agents such as decitabine, azacitidine, sometimes even considering gemtuzumab. Now, unfortunately, with all of these agents, they are not very durable and they will not lead to cures. So you'll see on the next couple of slides, we're starting to use decitabine, azacitidine as our backbone, but adding agents to them. Glasdegib is a new kid on the block. It's a hedgehog inhibitor. In this BRIGHT study, patients were randomized to Glasdegib with low-dose Ara-C versus low-dose Ara-C. And these patients were older patients, and they were not fit for intensive chemotherapy. The primary outcome was overall survival. In this study, Glasdegib improved overall survival compared to low-dose Ara-C. Now, low-dose Ara-C, you didn't hear me talk about at all. It's not really a standard of care in the United States. And so Glasdegib improved survival against really a non-standard of care. QT prolongation is something that we'll monitor. Also, patients can describe a loss of taste or a change in how they're tasting things. Patients can have quite a bit of nausea from this medication. There are some drug interactions that you should consider, but for the most part, even with strong inhibitors, it's more of something that I just monitor for as opposed to doing any dose reductions. The VIALE-A study randomized patients who were unfit for intensive chemotherapy to either venetoclax with azacitidine or to what I would consider was the previous standard of care, azacitidine. The overall survival was the primary outcome. And overall survival was improved with the addition of venetoclax to azacitidine. Typically, older patients with AML do not live past a year. In this case, we surpassed that milestone. So definitely improvement for older, unfit patients with AML. The Viale-C was also a venetoclax-based therapy regimen. In this case, venetoclax with low-dose Ara-C compared to low-dose Ara-C. Again, I don't really consider low-dose Ara-C a standard of care. However, in some cases, perhaps some use this. The primary outcome was overall survival. And to no surprise here, venetoclax added to low-dose Ara-C improved survival. Survival wasn't all that great, but this is a regimen that is available to patients now. There was a pretty big learning curve to figure out how to use venetoclax because this type of therapy was very different than our intensive therapies. It was different even than using our hypomethylating agent alone. Adding venetoclax improves responses. They make responses faster. So instead of having to wait 4 to 6 cycles, we can see responses after a cycle or two. And so what we'll typically do is get a day 28 marrow. If the patient does not have any evidence of leukemia, we give them a break because this regimen can lead to significant prolonged myelosuppression if we don't give them breaks. If we go in their marrow on day 28, we still see quite a bit of leukemic blasts, we'll just start them on their next cycle. The other thing that you should know is that venetoclax requires significant, about a 75% reduction when we're using strong CYP3A4 inhibitors. And so something to consider and remember. Also, something to consider is to stop antimicrobial prophylaxis when the patient has attained remission. The other thing that we'll consider doing is shortening the course of venetoclax and or the hypomethylating agent to help with the cytopenias if they occurred with previous courses. Ivosidenib was approved based off of this phase 1b dose escalation study where patients were administered ivosidenib. These patients had to have an IDH1 mutation. This is an oral medication that we continue until progression. These are patients that are older patients that are unfit for chemotherapy. Overall survival hasn't been reported yet. The median time to complete response is about 3 months. Some patients take a long time. So that's something to note is some patients can take 4, 5, 6 months before they attain a complete remission, which is different than our other therapies. Two main side effects I want you to remember. One is certainly can cause QT prolongation. However, differentiation syndrome with our IDH1 and 2 inhibitors. We'll talk about differentiation syndrome a little bit more in the APL section. However, this is something that is unique to ivosidenib and enasidenib. Also, there are drug interactions, and I would consider a dose reduction for ivosidenib if you're using posaconazole, voriconazole, or another strong CYP3A4 inhibitor. Although the response is quite similar between an IDH1 and an IDH2 inhibitor, enasidenib, there are slight differences with their safety. And so enasidenib can actually cause a hyperbilirubinemia. I usually just treat through this. And ivosidenib can cause QT prolongation. Enasidenib can cause decreases in calcium, potassium, and phosphorus. They both can cause differentiation syndrome and hyperleukocytosis. The reason why the hyperbilirubinemia happens is because enasidenib can actually inhibit UGT1A1. And here is your NCCN recommendations for how to treat older patients that cannot tolerate or decline intensive therapy. You'll notice that decitabine venetoclax or azacitidine venetoclax have really come to the forefront as the standard of care, especially if patients don't have actionable mutations. And quite honestly, even if the patient has an IDH1 or an IDH2 or even a FLT3 mutation, decitabine venetoclax, azacitidine venetoclax works quite well for these patients. In patients that are older and you're thinking the patient's not even fit for venetoclax-based therapy and have an IDH1 or 2 mutation, that's when I would consider ivosidenib, enasidenib. And then if a patient has a FLT3 mutation, of course, you're going to add a FLT3 inhibitor to your backbone. And generally, your backbone in this case will be a hypomethylating agent. Now, this is something new. Remember, I said that there were two phases of acute leukemia treatment. One was induction, two was consolidation. But now we have a new FDA approval for maintenance therapy, and this is with oral azacitidine. This is the Quasar AML 001 trial that randomized patients who are not fit for transplant to either oral azacitidine or placebo. These patients were in remission, and we are just trying to maintain this remission. The primary outcome was overall survival. Oral azacitidine led to an overall survival benefit compared to placebo, and as such, the FDA approved this agent for maintenance therapy for patients that are not fit for transplant, that have intermediate or poor risk cytogenetics. When patients relapse, we have to go back to induction therapy, or what we call reinduction therapy. There are a couple of different salvage chemotherapy options. Some are HiDAC based, like FLAG-IDA, MEC, GCLAC, GCLAM. There are other options like gemtuzumab that are also possible. All of these are correct options. There's really no agent that stands out to be the best. You generally just have institutional preferences. For relapse refractory AML, we definitely should retest patients to see if we have targetable mutations. I do think that our IDH1 and 2 inhibitors, especially for older patients, are great options if they have an IDH1 or 2 mutation. Additionally, gilteritinib is now a standard of care if a patient has relapsed and has a FLT3 ITD or TKD mutation. This is based off of the Admiral trial that randomized relapse refractory FLT3 positive AML patients to either gilteritinib or physician's choice, which was a standard of care chemotherapy, whether it was intensive therapy or low intensive therapy. The primary outcome was overall survival. The Admiral study led to an improvement in overall survival, and therefore gilteritinib is now a standard of care for relapse refractory patients who have a FLT3 ITD or TKD mutation. For the most part, patients tolerate gilteritinib quite well. There are some laboratory abnormalities, LFTs, amylase lipase can go up. They can be prolonged cytopenias, especially if we don't get patients in remission. Gilteritinib can also cause differentiation syndrome, although I will say it's not as pronounced as our IDH1 and 2 inhibitors, and definitely not as pronounced as our APL therapies. I will say that many patients do complain of myalgias. There are drug-drug interactions, as with almost all of our oral agents, so something to consider. To summarize how we treat AML, for induction, I would really look at those flow charts and diagrams that I created from NCCN. That's going to tell you how you're going to treat your patient, whether they're less than 60, greater than 60 but fit, or an unfit patient. After induction, we do consolidation, and we do consolidation generally with HiDAC if you gave them intensive therapy, or a patient that has intermediate or unfavorable cytogenetics, they'll go to transplant. And then also for consolidation, depending on if you use liposomal daunorubicin cytarabine, you will consolidate with that. And now for maintenance therapy, we have a new formulation of azacitidine that is FDA approved and used for patients with intermediate or high-risk cytogenetics that are in remission but are not candidates for an allo transplant. Acute promyelocytic leukemia, or APL, is a subtype of AML that has a very favorable prognosis. It is characterized by a translocation in chromosome 15 and 17. There are two things I want you to remember about APL. One is that within the first 72 hours to a week, you can see DIC, and this can unfortunately lead to high rates of mortality. And the second thing, especially once we start our ATRA or arsenic, is differentiation syndrome, which can also lead to mortality in this very, very favorable risk subtype of AML. We classify patients' APL risk based off of their white count for the most part. So if you have a white count greater than 10,000, you're going to be a high-risk patient and you're going to require a little bit of chemotherapy. If your white count is less than 10,000, you're a low or intermediate risk patient, and those patients typically do not require any chemotherapy, just ATRA and arsenic. ATRA and arsenic have revolutionized how we treat APL. And, as long as you can get your patients through differentiation syndrome, patients are going to do very, very well. Listed here are some of the side effects that you should know about with ATRA and arsenic. As I said, patients with high-risk APL, so they present with a white count greater than 10,000, they're going to require some chemotherapy added to their ATRA, whether that's idarubicin or gemtuzumab. So there's a couple of different regimens out there. I typically like to use the APML4 trial. Contrast that to low-risk APL. You do not need to give any chemotherapy. You don't need to give idarubicin. You don't need to give gemtuzumab. You don't need to do the APML4 study. You can just do ATRA and arsenic, and this is based off of the Lococo paper that showed incredible outcomes for patients with APL. LJ is a patient with high-risk APL. He presented with a white count greater than 10,000, and therefore you had to give chemotherapy with your differentiation agents. In this case, you gave gemtuzumab for their high-risk APL. On day 15 of LJ's treatment, his white count is quite low, but his bilirubin is starting to rise. It's 4.5. He has fevers. He's got a 10% weight gain. He's got painful hepatosplenomegaly. And on ultrasound, you see ascites and reversal of portal flow. Which of the following best describes LJ's symptoms? Is it A, coagulopathy, B, urosepsis, C, sinusoidal obstructive syndrome, or D, differentiation syndrome? In this case, unfortunately, LJ is experiencing sinusoidal obstructive syndrome. Now, there's quite a bit of overlap here in this patient's case with differentiation syndrome. The weight gain, the fevers, that certainly can happen in differentiation syndrome. Here, the chest x-ray is unremarkable. Usually with differentiation syndrome, you'll also see chest x-ray infiltrates because there's quite a bit of capillary leak and cytokines that are being released. In this case, the patient's reversal of portal flow, the ascites, the high bilirubin really is all pointing to SOS. And we do know that gemtuzumab is notorious for causing SOS. Differentiation syndrome occurs because of our differentiating agents, ATRA and arsenic. ATRA and arsenic force these immature cells to mature, and when they do this, they release a tremendous amount of cytokines. Your white blood cells start to rise. The cytokines cause capillary leak. Capillary leak leads to fluid kind of all over the place. So the patients get weight gain. They can hypoperfuse their organs, and all the signs and symptoms of APL are listed on this slide, and they all make sense because now you understand the pathophysiology. The treatment of APL is a marathon. It's not a sprint. Every single patient will go into remission. You just have to get them there. There is no rush. Safety first. Every center that I've been at, pharmacists are always the ones that remind their team, hey, this patient's having severe differentiation syndrome. Let's hold our differentiating agents. So in patients with milder symptoms, you can continue their differentiating agents, but definitely start dexamethasone. In more severe cases, I would hold the therapies and give dexamethasone. To summarize the treatment of APL, high-risk patients present with a white count greater than 10,000. They need chemotherapy to cytoreduce them, in addition to ATRA, with or without arsenic. Lower intermediate risk patients present with a white count less than 10,000. They do not need any chemotherapy at all. ATRA and arsenic, standard of care, that's all you need to do. Monitor for DIC, help your team with differentiation syndrome. APL, done. We'll move on to our last topic, acute lymphoblastic leukemia. DH is a 26-year-old male that complains of bone pain, early satiety, and frequent headaches. Presents with a white count of 80,000, 40% are lymphoblasts. He is diagnosed with Philadelphia chromosome positive pre-B-ALL. Which of the following is the optimal remission induction therapy? Is it A, the CALGB 10403 trial, B, the CALGB 9511 trial, C, mini-CBD plus inotuzumab plus ponatinib, or D, hyper-CVAD plus ponatinib? The correct answer here is D. A and B are both incorrect because they are not including a tyrosine kinase inhibitor, and this patient has pH positive B-ALL. C would be incorrect because mini-CVAD or CVD with inotuzumab is not a standard of care frontline therapy with the addition of ponatinib at this time. Acute lymphoblastic leukemia is the other acute leukemia. So instead of being myeloid blasts, we have lymphoid blasts, or very immature cells. And we can have B cell ALL and we can have T cell ALL. For all intensive purposes, from an adult perspective, for the most part and for testing purposes, we do not treat these diseases any differently. We do stratify and treat differently based off of age. So an adolescent young adult patient is treated different than a patient between the ages of 40 to 65. And our older adults are particularly challenging to treat, and they get different chemotherapy regimens. The way that we provide our patients with a prognosis in ALL is we subcategorize them into good risk or poor risk ALL. We use a variety of factors: cytogenetics, their white blood cell count, their response to therapy, and their age. And as patients get older, they just have a worse and worse disease biology. They tolerate therapy less, and therefore their outcomes are worse. Some things that I want you to take home from this slide are patients with Ph positive ALL, they do worse. Patients with a much higher white count do worse. Patients that are MRD positive or measurable residual disease positive, they do worse. In addition to Ph positive ALL, which has the BCR-ABL translocation, the 922 translocation, there's a somewhat newer subtype that we're calling a Ph-like that has a gene expression profile that's similar to Ph positive but doesn't have the BCR-ABL translocation. These patients also have a poor prognosis. Unlike in AML, which only has 1 to 2 treatment phases, in ALL, we have multiple. It can get quite confusing in ALL to follow some of these protocols, and the nomenclature of the phases are different depending on the protocol. Everyone has a remission induction, which aims to put our patients into a complete remission. But then many protocols will then move on to consolidation, whereas some call it intensification. And then they move on to delayed intensification, and then they move on to continuation, or some will call it maintenance. So it gets quite confusing. But what you should know is that there are multiple phases of ALL treatment that span about 2 to 3 years of therapy. And intrathecal prophylaxis is throughout these phases is very important to prevent CNS relapse, or central nervous system relapse. This is obviously a oversimplification of how we treat ALL, but I think oversimplifying is the right thing to do here. The way that we'll treat ALL is based off of a couple factors. The Philadelphia chromosome positive patients, because they're going to get a tyrosine kinase inhibitor, and then their age. Younger patients are more likely to get a pediatric type regimen with asparaginase. And then the third thing is the patient's performance status. Over the past 50 years, we've learned that our anthracyclines, vincristine, corticosteroids are very important for the treatment of ALL. We've also learned that pediatric patients require asparaginase for good outcomes. We've learned also that our adolescent young adults can benefit from the use of asparaginase. The way we define adolescent young adults is different depending on which cooperative group is studying this. However, for the most part, I would say most of us consider patients of the age of 16 to 40 years of age adolescent and young adult. And what we have found from multiple retrospective studies and phase 2 studies is that if you treat an adolescent young adult patient with an adult regimen, they will do worse than if you treat an adolescent young adult patient with a pediatric regimen. Recently, Wendy Stock and the CLGB group published this pediatric regimen that was used in adolescent young adults. These are patients of the age of 17 to 39, and they were treated with a pediatric-inspired regimen. The primary outcomes are listed there. The first 2 bar graphs listed here are historic controls, and the third bar is results from the phase 2 C10403 trial. You'll notice that if patients are treated with a pediatric-inspired regimen, their event-free survival is better than if you treat them with an adult regimen. As such, you'll notice that for Philadelphia chromosome negative ALL, the NCCN guidelines recommend that for patients who are an adolescent young adult, that they should get an adolescent young adult based treatment, whether it's the C10403 or others listed here. For an adult patient, it's important to balance the tolerability and the toxicities, which many times older patients will not tolerate the intensity of a pediatric-inspired regimen. So a lot of people will use the hyper-CVAD regimen for adult patients or the Larson protocol. Others are listed here. And for elderly pH-negative patients, there are a variety of options here. Now, as you can see, no one can agree on what is the best therapy for any of our patients, and therefore you have multiple right options. It's actually quite challenging to come up with a wrong option when creating some of these questions. For Philadelphia chromosome positive ALL, we also can't decide on what is the best or the right backbone chemotherapy. However, we do all agree that we should add a tyrosine kinase inhibitor. For testing purposes, I think any of the tyrosine kinase inhibitors are appropriate. Like with AML, after we get our patient in remission, if we don't give our patients any more therapy, virtually all patients will relapse. And so what we do is we provide them with post-remission therapy, and then we get them on maintenance therapy. And we use different agents. You can take a look at your handout for a variety of commonly used maintenance therapies if you'd like. Identifying, monitoring, and treating measurable residual disease is now a thing in ALL. MRD is when you look at a bone marrow sample under a microscope and you see absolutely no disease with your visible eye under the microscope. But when you take a deeper dive by more sensitive tests like flow cytometry or PCR, you can now detect or measure residual disease. Having MRD is a poor prognostic marker. It essentially indicates that your cells are chemoresistant. In the past, we did not have any therapies to treat these patients, and we were kind of just forced to take them to transplant, even though we knew that their outcomes were going to be poor. And now we have blinatumomab for patients with measurable residual disease, and its FDA approval was based off of the phase 2 BLAST trial. To provide you some context, typically patients with MRD positive disease will relapse within 6 to 12 months. Their outcomes are quite poor, and most patients don't live past a year. You can tell from the BLAST trial here, although it's non-comparative, the outcomes were dramatically improved. Although blinatumomab does not have similar toxicities to our traditional chemotherapies, we do see some unique toxicities with blinatumomab. First is cytokine release syndrome. The second is neurotoxicity. I'll provide a little bit more information when we talk about CAR T-cell. Based on the BLAST trial, the FDA did approve blinatumomab for patients with measurable residual disease. You should know that the dosing is different for MRD and the titration is different for MRD compared to when we use blinatumomab for relapse refractory disease. And the duration of hospitalization is shorter for MRD positive than if we used it for relapse refractory disease. Speaking of relapse refractory disease, traditionally we used to use quite a bit of chemotherapy for relapsed ALL. Now we are using more novel therapies, inotuzumab, blinatumomab, and then CAR T-cell if the patient is less than the age of 26. In addition to blinatumomab's approval for MRD positive disease, it was also approved for relapse refractory disease based off of a phase 2, which was confirmed in the phase 3 TOWER trial, which showed an overall survival benefit in relapse refractory patients compared to chemotherapy. Blinatumomab is a continuous infusion, because it has a very short half-life, a continuous infusion for 4 weeks on and then 2 weeks off. The patient will spend the first 10 days in the hospital for relapse refractory disease. For MRD, remember on the previous slide, they're only in the hospital for about 3 days. This is so that we can watch for cytokine release syndrome and the neurotoxicity. We have different bags, 24 or 48-hour bag, and now a 7-day bag. The 7-day bag does contain preservatives. And so for the pediatric patients, there's specific weights that you cannot use the 7-day bag for. Inotuzumab is also FDA approved for relapse refractory ALL, and this is based off of the phase 3 INOVATE study, which compared INO to chemotherapy and showed an overall survival benefit. There are two things that you should remember. One is VOD or SOS that we talked about that happens with gemtuzumab, and if your patient is going to go to transplant, they have a higher risk of non-relapse mortality, very likely due to the toxicities of inotuzumab. A 33-year-old female with Ph-negative B-ALL is being treated for her relapse refractory ALL with blinatumomab. On day 2 of blinatumomab, the patient has emesis with rigors, a fever to 39, and some abnormalities in her LFTs. You diagnose her as having grade 1 cytokine release syndrome. Which of the following should be employed to treat her CRS? Is it A, supportive care, B, you should stop blinatumomab, C, tocilizumab, or D, dexamethasone? The correct answer here is A, supportive care. This patient is only having grade 1 cytokine release syndrome, and therefore I would not stop blinatumomab. I would only stop blinatumomab if we're hitting grade 3 or higher. I also wouldn't give dexamethasone unless the patient is having grade 3 or higher CRS. Tocilizumab, typically what I'll do is if I'm considering tocilizumab, I stop blinatumomab, let them cool off before considering tocilizumab. However, per the NCCN guidelines and a couple other guidelines, tocilizumab would have been appropriate if her grade 1 CRS lasted for several days or it ended up escalating to grade 2. SB is a 28-year-old female receiving CAR T-cell on a clinical trial for her relapsed B-ALL. Which of the following medications should she initiate on the day of CAR T-cell infusion? Is it A, corticosteroids, B, levofloxacin, C, levetiracetam, or D, resbiricase? Levetiracetam C would be the correct answer. We will add this on day 1 of the CAR T-cell infusion and typically continue this for 30 days because neurotoxicity and seizures are possible with CAR T-cell. Would not recommend giving steroids. You don't necessarily need levoprophy. Resbiricase is generally not indicated just because you're giving CAR T-cell. CAR T-cell is a therapy where we take a patient's T-cells, we re-engineer them and direct them towards the patient's CD19 positive B-ALL. And unfortunately, it's only FDA approved for patients under the age of 26 at this time. Like with blinatumomab, cytokine release syndrome can also happen with CAR T-cell. And this is because both therapies are activating your T-cells. And the activated T-cells are leading to a profound amount of cytokines. The cytokines cause capillary leak, they can cause fevers, they can cause hypotension, and multi-organ failure. So this is definitely a life-threatening complication that, for that reason, a blinatumomab needs to be given in the hospital for a certain period, and CAR T-cell has to be given at specific centers that are REMS approved. In addition to cytokine release syndrome, we can also see neurotoxicity with both blinatumomab and CAR T-cell. It usually manifests within the first week or so of therapy, and patients can present with complete altered mental status. Some patients can get better within a couple of days with treatment. Unfortunately, some patients can have irreversible neurotoxicity. Some patients can have seizures with CAR T neurotoxicity, and therefore levetiracetam is often given as prophylaxis to prevent seizures associated from the ICANS. What makes it challenging when you're reading through the literature is there's multiple different grading systems for CRS and ICANS that have evolved over the years. I typically will now use the ASTCT grading for CRS and neurotoxicity. And this is how we treat these potentially life-threatening toxicities, CRS and ICANS. For grade 1, supportive care should suffice. For grade 1 CRS that's lasting for greater than 3 days, you can bump them up to grade 2 and treat them as such, which consists of tocilizumab. You'll notice that ICANS, we do not use tocilizumab. In grade 2 and higher, we use steroids, and that's because tocilizumab can actually worsen the neurotoxicity. I would become intimately familiar with this table. I think it's important. You'll notice that there are some agents that are probably used in practice that are not here, but that's beyond the scope of this presentation. To summarize the treatment of ALL, adolescent young adult patients should receive a pediatric-inspired regimen. Ph-positive ALL should receive a TKI. Patients with MRD-positive disease should receive blinatumomab. For relapsed refractory disease, inotuzumab, blinatumomab, and CAR T-cell are all options. Thank you very much.